Welcome everyone to this November's Learning Collaborative meeting on infantile spasms and infantile epilepsies. We're going to be started with a 15-minute didactic followed by a quality improvement discussion.
Sounds great. So welcome everybody. We're going to do sort of a collaborative talk. So Renat Jonas is beside me. She did the bulk of the preparation for today's meeting. And we'll be showing you some interesting videos, I hope, that will promote some discussion. So for today's objectives, we want you to be aware of the most common infantile epilepsy syndrome, which is indeed infantile spasms or West syndrome. We want you to understand the natural history of infantile spasms, and then recognize the importance of early recognition and treatment. It's really this last point that we think is so important. And I know, Jay Marie, you've shared patients with us as well, so you're well aware of this syndrome. We're going to start with some cases, hopefully to bring it a little bit more meaning. So case one is a 4-month-old girl who had a normal birth and developmental history. In the last few weeks, she has become more irritable and colicky, and upon awakening has clusters of her extremities flexing and then crying. So here's a video. I'm gonna play it. You're gonna hear our voices a little bit softer perhaps. Question is this just colic? Is it cries? Oh, got a little poll question. Let me pause it for a second. So I don't know if you were able to see that quickly enough. So let me play it a little bit longer before you answer. Let's try it again.
She's crying and then she's flexing her upper extremities and lower extremities.
And when she does that, she stops crying. Somewhat of a forceful flexion. So if I can ask people to poll and to answer that, that would be great.
Well, the left leg was shaking a little bit, but then when she stopped crying, both legs kind of flexed at the hip, which looked kind of unusual.
Let's look again.
Let's look again. Right there, she's kind of got, there we go.
Yeah, that thrust up.
So when she's crying, to me, that's probably the part of her returning, and that's the actual event. The flexion is the event, and then I think the other one is sort of random movements that she makes when she's irritable. So if you want to answer, it's okay. We're not, we don't give a grade on this.
So if everyone could give a guess, it's totally anonymous.
Yeah. Yeah, we're all doing it. We're having everybody, Christina and Sarah have to participate too, just so that you're all mixed up in there.
But Jane can directly just say what she thinks.
Yeah. Jane, what do you think?
Who, me?
Yeah, what do you think?
I
said yes.
I think we've got 100% yes. Were we right?
You were all right. Yes, absolutely. And it can be hard, which is what, as we talk a little further, you're going to understand. So, let's see, why isn't it going? There we go. Okay. So indeed, that was infantile spasms. Now, the only way you really know truly is with an EEG, but it was concerning for a variety of reasons. We just talked about a 4-month-old girl, and it happens to be that the first description of this was about a 4-month-old boy, first written by Dr. West himself, who was a surgeon, dating back to Lancet in 1841, and he didn't know what it was. So he actually put an entry in the journal asking his colleagues in medicine as to what is this and have they seen it before. And the original descriptions were of slight bobbings of the head forward, and the bobbings increased in frequency and strength with time. And then at 1 year of age, he neither possessed the intellectual vivacity or the power of moving his limbs of a child his age. So really talking about there was some kind of event that happened He wasn't sure at the time it was seizures, but we know now that those were infantile spasms, and it really altered this child's development. And that's where we're talking about the epileptic encephalopathy. It's not just the seizures, it's how it impacts development.
So let's talk a little bit about the features of this syndrome and some points that might help us identify a little bit easier this syndrome compared to some normal baby movements. So one important thing that it's a very age-specific epilepsy, which means you usually would not be 3 years old, or you usually would not be 1 month old when you have this spasms. It's relatively common. It's about 1,200 to 2,500 cases per year in the United States. And we see just in B and C probably 3 to 5 a year. So it is relatively common. We have to know it. Usually the peak age of onset is between 4 to 6, 7 months. However, it can start a little bit earlier and start a little bit later. If it starts much earlier, we have to think about some etiology like cortical malformation or a genetic etiology rather than what we call idiopathic infantile spasm, which would be a child who was initially developing totally normally. And the spasms can have, like Jane said, you said it looks a little bit strange what this kid is doing. So it can have multiple actually presentation, and it depends on which muscle groups are involved. It can be just the flexor muscles, and then you would have flexion of the upper and lower extremities. It can be extensor muscles, and then you have extension of the upper and lower extremities. Or the most common one is mixed, where you have either upper extremity flexion and lower extremity extension, or the other way around, where we probably see mostly, which is the upper extremity extension and then the flexion of the neck, and the lower extremities many times flex with it. And interestingly, it clusters. And this is one thing that would help you if you see a baby that does it here and there, but if it happens 10, 15, 20 times in a row, usually each of these spasms is going to be between 2 to 10 seconds long, but the cluster itself can sometimes last up to half an hour, sometimes less. You can have between 10 to 100 spasms in each of this cluster, and the timing is very helpful. So you usually don't see it when the babies are sleeping, very rarely. We usually see it when baby is in transition from sleep to arousal. And that would be one of the questions to ask to differentiate, for instance, between colic and spasm. However, it can be very, very subtle. So you might not see at all this major motor manifestation. You might have just a little bit of isolated eye movement. You might have some yawning. The cluster, each spasm in the cluster may look a little bit different. They might be in the beginning very subtle and then become a little bit more pronounced. And they may be focal, so might be only one side that is actually involved, or they might have some autonomic features, especially flushing. They became very red, and then we think about, oh, the baby has constipation and they are just pushing. So it can be sometimes hard to differentiate. Quite common is the cry, like we saw with this little baby Helen, that goes along with the spasm. Anything else you want to add for this?
No, I think that's great.
Jane, do you have any questions?
No.
All right. So what can it be? It can be just normal baby movements, right? We know that babies are kind of a little bit sometimes jittery, a little bit irritable. They just might kind of move. They might have reflux or colic, which I think is probably the most confusing differential diagnosis. And we have few babies that came to us after initially it was thought that they probably have colic or reflux. It might be the different seizure types, or it might be some other movement disorder that babies might have, like tremors or chorea and so on. So we're going to show you another case, okay? And this is also a little baby, about the same age as the other one, also totally normal development. It's actually thriving okay, but a little bit less than what we would like to. And usually about half an hour after feeding has this paroxysmal abnormal movements. So here we see extension of the upper extremity, of the neck, head. You hear the cry. Another one. He always stops crying during it. And you know, the video went on. He has at least 5 or 10 of them going on. So is this infantile spasm? Jane, what do you think? Sorry, you're the only one that.
All right, no,
Oh, no, we have several answers. So we had 3 yes.
Okay.
But it almost it looks like reflux. I'd like to see it. Well, it looks very exaggerated, but it almost seems like reflux, but it's very exaggerated. That's the only thing that worries me.
Yeah. So you're totally right. This is actually a baby that suffers from reflux and has the kind of typical, almost epistotonic posture that we call the Sandifer syndrome. However,
what was that? Sorry, we're having a little hard time hearing you.
Oh, let's plug back in.
So, what about the plug?
Okay, can you hear us better now?
Yes.
Yes,
Very good.
So Jane, I said you were totally right. This baby has reflux. It is maybe a little bit more severe than what we sometimes see. However, these babies might get into this abnormal posturing, a little bit like an epistotonic posturing, and it's called Sandifer syndrome. But that would be a baby that you would need to take much more extensive history to try and differentiate it. And that might be a baby that would actually end up with pediatric neurology for workup, and it would be totally justified.
Right.
How often does the post-feeding and post-awakening coincide? So if you had a baby and you typically give your baby a bottle after a nap, would that timing be similar for infantile spasms and for colic?
So the infantile spasm is less food dependent, so you would think it's less related to feeding.
It happens like as soon as you wake them up.
Okay.
It's not like 20 minutes later after they've woken up and then had the bottle. And sometimes, you know, probably Carrie and Jane Marie who are online and do primary care, you know, you get a history that they're somewhat positional for the kid with the Sandifer syndrome, which makes a little bit of a difference. But it can be confusing. And like Dr. Jonas said, it would be very justified to do an overnight EEG on this baby. Chances are if this baby if it's GI, has a lot of distress anyway, it is probably a pretty sick kid given how severe that example is. So I think a workup is justified.
So there are multiple etiologies for infantile spasm, and nowadays about 70% are called symptomatic, which means we actually know the reason. And about 30% are called cryptogenic, which means, you know, we don't know the reason, but we think that there is maybe a cause for it. And about 3% of this 30% are the idiopathic kids, which we actually never find the cause, and they actually can do very, very well if they receive treatment early enough. So probably one of the most common one is malformation of cortical development. And tuberous sclerosis is probably the most common genetic syndrome or any disorder that actually goes along with infantile spasm. Genetic disorders, important to think about children with Down syndrome, trisomy 21, it's actually quite common. And then a little bit less common, but we do see inborn error of metabolism. For instance, some of the pyridoxine or B6 dependent or deficient epilepsies that can present like that. Hypoxic ischemic encephalopathy is a very common cause.
What we mean by that is the baby had a neonatal hypoxic ischemic encephalopathy.
Yeah, so baby who were born with some kind of an anoxic event, and they maybe had neonatal seizures, and it most likely at that point was focal motor seizures. They might then develop at age 3 to 4 months infantile spasm. So for instance, this is one of the things that we actually warn the parents about at discharge, to look for these events that look like spasm. And then of course, any CNS infection, any stroke, and we're talking mostly about perinatal strokes that can cause that. And then trauma, so shaking baby syndromes, and like I said, about 30% that are unknown. So what do we do for workup? So of course, history, number one, and a few questions that can help us are the clustering, the seizures or spasm that happen when you wake up. Important to have a good physical examination. And usually this kid should have a Woods lamp to try and identify the ash leaf spots that are hypopigmented spots that children with tuberous sclerosis may have. We can also look at some asymmetry. So sometimes we get a clue that the parent says, you know, the baby is 4 months old, but reaching mostly with the right hand, and we don't see them moving so much the left. So any motor asymmetries. It's really important.
What is a Woods lamp?
Woods lamp, it's an ultraviolet lamp that you need to kind of look at the baby's skin in a dark room. And it lights up. If they have this hypopigmented spots, you can see them much better.
It's like a blue light.
So
it's like how white, you know, how white shows up in a blue light.
Yeah, so children with very fair skin, you might not be able just to see it, you know, with your eyes. It's very important to have a prolonged EEG, and it's very important to capture these events during the EEG, because the typical features that we see on the EEG, which is the hypsarrhythmia, is not always present all the time. It might be just present at sleep time. It might be just present some of the sleep. So it's totally not, it's not enough if we do just a routine EEG. All these children are going to have a brain MRI. And then depending on what we find, genetic testing or some metabolic testing. And if we look here, we have two pictures of EEG. So if you look at this one, you just see kind of a big mess, all right? Or even for somebody who kind of doesn't know to look at EEGs. We have here the right side of the brain, here kind of the left side of the brain, and again here right and left. It's a very, very high amplitude EEG, the background with a lot of spikes intermixed with a lot of slow activity. And during the spasm itself, it's kind of interesting. There is actually almost normalization of the background. We see this kind of a sharp wave followed by what we call a small decrement, so that there's kind of a decrease in the amplitude of the background. And so if you have this abnormality all the time, and then you have actually a decrement, that's kind of easy to identify. And that's how the ictal phenomena is during the spasm. And let's look at another case. So this is the kid that is also about 4 months, is developing quite nicely. However, mom noticed that he's moving better one side. So he just started to reach, and he reaches more with one hand, and now started to have the spells that we are going to see. You want to take this out?
Yeah.
A disappointed Prince Harry speaks out why he's being pulled from combat.
Grimacing.
Pretty loud.
You make the worst time have meaningless arguments. This is a game about purpose.
His right hand was moving a little bit now.
See. Why don't you take it?
I'm recording it. So now both hands left.
You see that within the cluster itself, it might change a little bit. How each spasm looks like. He is not crying in between, but he clearly has a facial grimacing with some of them.
Like that. You get the sense that although he's not crying, he's a little distressed in between.
Yeah.
This whole thing is just what it is. Take
You just slide it over.
I just want to ask you, do you
It's kind of continuous. So, who wants to? Oh, we see we have more participants.
So we have Dr. Bell and Tanya Bibley from Manic Community Health Center joining us as well. Thank you guys both for coming.
So the question is do you think that's infantile spasms? I know you're just joining, but we've shown a couple of videos today. Some have been infantile spasms, some have not. So it's just a broad poll.
And it's anonymous.
But you can screen.
It looks like it to me.
Okay.
What
Yeah.
is it about it that makes you think it is?
It was like the face would like bob down and it was involuntary, like one arm, but then it would switch sometimes. But then in between, he's like grabbing and everything, and it seems like a complete involuntary movement with
I agree.
kind of scrunching up and the hand extending.
Right.
Right.
It's hard, you know, if you've ever seen shuddering spells though, and the baby were a little bit older and you were sitting in the high chair doing this, we might feel a little bit differently.
Right.
Mm-hmm.
So shuddering is a benign movement disorder and the babies sort of tense up a little bit and they tremor a little bit. And so it can be hard. This little baby lying down flat makes it a little bit easier maybe to identify. And I agree that there was some focality. Sometimes it was the right arm going a little more, sometimes it was the left, and then it was both. But I think everyone agreed it was involuntary.
Yeah. So this is again a baby that has infantile spasm, and I think some of the focality that we see here and some of the points in the history that mom says that one side is of the arms is actually the baby is reaching more, we would kind of be concerned about some kind of structural abnormality. And the point that we would like to bring here is that what we see in the MRI at a young age, before age 1 to 2 years, when there is no complete myelination yet of the white matter, is actually not very accurate, because we would see major malformation, but subtle malformation we are not going to see. And the treatment for children who have, let's say, a focal cortical dysplasia and spasm is usually surgery. They might respond initially to a medical therapy, pharmacological therapy, but many times they don't. And if we identify early enough that it is actually a structural abnormality, surgically we can improve their prognosis. And if we look at this MRI at age 6 months, and usually what we are kind of looking at with subtle cortical malformation is in the borders of the white and the gray matter to see how sharp the border is. And it looks relatively symmetric. However, when we look at the same baby at age 3 years, it's very clear that the white matter here on the left side is better developed than the white matter on that side. And this is a baby who had a focal cortical dysplasia, who then later had a surgery. However, by the time that he had the surgery after age 3 years, he was already quite delayed and regressed. So a point is, if we don't find it on the first time with the MRI, we need to look at other modalities if we suspect. There are PET scans. There's nowadays a lot of other imaging modalities that we can use. And we repeat the MRI. So the treatment for infantile spasm kind of evolved from the 1840 when it was first described by Dr. West, with leeches and lancing of gums and warm bath and syrup of poppy to nowadays the two first-line drugs, which are ACTH. ACTH is shots that are given on a daily basis. Nowadays, the recommendation are to give high dose, short duration. So usually it's for 2 weeks. Then with a slow titration, or with a relatively fast titration that can be done either with ACTH or prednisone. This would be the first line probably for us for everything, at least in our group, except for tuberous sclerosis, where we know that vigabatrin is very, very effective. Definitely for the children who are idiopathic infantile spasm. So we don't find any cause or any reason, and they're doing well, and there's no clear regression, or even if there's a minimal regression, this kid can do very well on ACTH. Of course, all the side effects of ACTH that we saw in the past when we use it for a long duration, we saw cardiomyopathy, we saw hypertension, we saw hyperglycemia. We don't actually see it nowadays when we give it for a much shorter time. And vigabatrin would be the first line for tuberous sclerosis. We sometimes use it, or many times we use it after the ACTH if the baby did not respond within 2 to 3 weeks. The major side effect of vigabatrin is visual field restriction. It's very hard to identify that actually in these little babies, but some babies, especially the ones who had an hypoxic ischemic event at birth and their vision is anyway quite impaired, that would be a very good choice. And we have multiple babies who did not respond to ACTH, but did respond to the vigabatrin. And one thing that we didn't really say in the beginning, which is kind of maybe important with the clinical semiology of spasm, and that's where you guys, the pediatrician, that's your kind of job. I find many times that the age where they start having it, it's something between 6 to 9 months. And the pediatricians see them at 6 months at well child care. And then they see them at 9 months at well child care. And at 6 months, the baby was doing fine, had good eye contact. And in 9 months, there's not good eye contact anymore. And this is one of the first signs of regression that we actually see in the babies with infantile spasm, that they lose the eye contact. In a lot of centers, they use PO prednisone. There's quite a few trials going on now to try and see whether high dose PO prednisone would be as efficacious as ACTH. I have to say that despite the fact that a lot of centers are using it, we don't have yet good studies that would show that it is as good as ACTH. We here in BMC use still ACTH as our first line. And then there's a lot of other medication that we can use as second line, like topiramate or zonisamide or Depakote or clobazam or morphinamide. There's not really good studies that show that any of them is very efficacious. In some places like Japan, they use high dose B6, even for children who do not have the metabolic disorder that is called pyridoxine-dependent epilepsy that can present with infantile spasm, and for them the treatment is B6. We have multiple babies on ketogenic diet, and there are some centers that start as first line with the ketogenic diet. And like I said, there is a small percentage of children who have a clear cortical malformation, and epilepsy surgery can make a big difference. So what is an effective treatment for infantile spasm? And I think if you read some of the studies that are done, you actually see that a lot of the kind of treatment, the treatment outcome were by parents' questionnaire. So do you see if your child still has spasms? And not all of them had actually prolonged EEGs to show that the baby not only stopped having the spasm, but also normalizes EEG. So both American Academy of Neurology and Child Neurology Society say that a responder is only the one that has complete cessation of the infantile spasm. So you don't see anything clinically, as confirmed by video EEG monitoring, not enough what the parents report, and elimination of hypsarrhythmia on a prolonged EEG. So even if we don't see anything clinically, but the baby has still this very abnormal, disorganized background, that's not good enough. We have to try and be more aggressive in the treatment. And that's what kind of Laurie said before, why we have actually an epileptic encephalopathy. I mean, we don't think that they're really the little jerkiness of spasm are the ones that are that kind of a prolonged or bad seizures that would cause all this regression. It's really the underlying etiology that causes all this mess in the EEG background that affects the child's ability to develop. So what is the outcome? So this is a study that was done actually in Israel on 20 children that, okay, let's start with that. So before I talk a little bit about the study, so really the etiology is the most important predictor. So if we had a child who had an hypoxic ischemic encephalopathy and is now very spastic and is cortically blind, we might be able to control the infantile spasm. However, we are probably not going to improve long-term outcome and prognosis regarding cognition and development. The same goes with some of the genetic disorders or some of the genetic mutation that we nowadays do identify. So etiology is the most important. But let's talk about the children who are idiopathic. So we didn't find anything. And they started quite good. And if we identify it early enough, and the study showed that they took 20 children who received their treatment within 2 to 4 weeks of the first spasm. And all 20 children received high dose ACTH, and all 20 children had normal cognition at follow-up, compared to children who were late. There were 16 children who started to receive the HCTH beyond 1 month of the onset of spasms, and only 40% of them had a normal cognition. And we talk about IQ above 70, so not all of them, we talk about IQ of 100.
I guess the other group that we kind of know the same type of information has been the Down syndrome population, where we know early treatment, even though these are kids who have a genetic syndrome that leads to intellectual disability, they too have better outcomes with early treatment versus late.
The same, for instance, there's a nice study on the tuberous sclerosis kids who are treated with vigabatrin. One of the predictors is how early and how fast were we able to treat, and were we able to get cessation of the spasm and normalizing the EEG. So the symptomatic group, like I said, depending on the etiology, the prognosis is usually not good for normal development. Infantile spasm, we said it in the beginning, is an age-dependent epilepsy. So you don't continue to have infantile spasm even if we don't control them. So it's an evolution, and depending on brain maturation, and it usually develops to another seizure types, many times tonic seizures, so much more prolonged tonic, 20-second, 30-second, rather than the brief spasm, usually by 1 to 2 years of age. Most of them develop what we call the Lennox-Gastaut syndrome, where they have multiple seizure types with tonic, atonic, generalized tonic-clonic, myoclonic, and atypical absence seizures. Their EEG changes from this high amplitude, disorganized, multifocal and generalized spiking wave to what we see in Lennox-Gastaut syndrome, which is usually slow spiking waves. So every about 1 to 2 seconds, we see spike with a very kind of slow background. And these children are usually developmentally impaired. Let's say if we cannot control the seizures, so really up to 90% of them have quite severe intellectual impairment. So what is the take-home message for you?
I have to tease you. You wrote take-home massage.
Oh,
This
sorry.
is going to be, this is an extra benefit for joining our learning collaborative.
I had you proof it and you didn't.
I'm seeing it now.
So the take-home massage. Infantile spasm is a medical emergency. They do not come to us if you don't recognize it. So you are really the front line. You do an immediate referral to a pediatric neurologist. This is the ones that you pick up the phone and we see this patient within 24 hours. These infants are most of the time admitted to the hospital for quick confirmation of the diagnosis and initiation of treatment. And like I said, we have now data that shows that early treatment started within 1 month of onset of spasm has a positive impact on developmental outcome and decreased risk for other seizure types. And our goal is no spasm, no hypsarrhythmia. And our goal for today is that if you guys are going to identify it and send it early, we did what we had to do. Any questions?
No.
Except for massage?
Exactly. Hopefully, I think the other thing that we just touched on is the side effects of the medication. And I think that's the other time that